Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back, everyone, for the third session, which will be about using AI in pathology. For this session, we will moderate the session myself, Ibrahim Al-Sani, and my colleague, Dr. Rana Shughrud. The first talk will be with Dr. Mohsen Bilal, which will be about foundational model in computational pathology, an era of diagnostic precision. Dr. Mohsen Bilal is an associate professor of computing at Prince Sultan bin Abdulaziz University and honorary research associate at University of Warwick Tissue Image Analytics Center. He leads the Artificial Intelligence and Complexity Research Group, focusing on frontier pathology foundational model and their translation into clinically useful tools. His team developed an end-to-end AI pipeline to shorten the time of diagnosis and improve quality of care, particularly in resource-constrained setting. Dr. Bilal's current portfolio span lung cancer, biopsy pre-screening, mutation prediction, and tissue microenvironment and genetic profiling, pursued in collaboration with multi-site partners across UK and the Kingdom of Saudi Arabia and the Middle East. Beyond research, he advises the healthcare leaders in trustworthy of AI, reproducibility, and workforce upscaling, aligned with the Kingdom's RDIA priorities. He also serves as a scientific committee of Asian Digital Pathology Association. At this conference, Dr. Bilal will highlight how leading pathology foundational models are reshaping computational pathology and advancing in patient management. Welcome with me, Dr. Mohsen. And just for the audience, please, if you have any question, just type it in the Q&A box. Also, if we don't have enough time, Dr. Mohsen will be around in the breakout rooms. Dr. Mohsen, the floor is yours.
Good afternoon. Thank you, Dr. Ibrahim, for the kind introduction. And thank you for the invitation as well. And thanks to all the attendees for joining today. So let me share my screen. Okay. So over the past decade, we have seen that AI has produced some excellent applications and some excellent results. And if we talk about deep learning in computational pathology, we have seen great results, I would say, in papers. But when we have to translate it into real world, that's somewhere we found a great deal of challenge, especially in pathology. And that's quite understandable given that the pathology is something which is much different in reality because of variety of labs and different endpoints that we want to predict and different scanners and variety of stains. And if the population shifts, all these are the challenges which arise at the time of deployment. And we haven't seen much progress in that area. Another great challenge, which is also a unique global challenge for the pathology, is that we cannot scale the expert time. Everything else, like cases and workload, is rising, but the expert time does not scale. So before we talk about scale, we need to get the precision right. So that's the title of my talk today. And that matters because that's the only reason foundation model actually matters. Because it should not be as another benchmark, it should be something which is safer and more generalizable to the real workflow. So let's start with the workflow. So before that, it's a quick disclosure. As Dr. Ibrahim has already introduced me, in today's talk, I have a couple of references from my past work that I have conducted while doing my postdoctoral research and a data scientist role at the University of Warwick. And I do not have any other conflicts of interest to declare. So I brought two pre-screening examples today. So this first one is colon biopsy pre-screening. And this is a challenge, an operational challenge, which we refer as a high volume of biopsies. And in that high volume of biopsies, we see many routine cases. So the idea here is to deprioritize likely normal cases so that we can identify abnormal cases early on and shift the focus of pathologists and experts from cases towards more care. So for that, we have developed two complementary approaches at the University of Warwick. And first one is Cayman that we have published in the Lancet Digital Health. Cayman is a short form of colorectal AI model for abnormality detection. And the second paper, which was published in BMJ Gut, is Iguana, where we integrated some of the interpretability in the aggregator for the whole slide image representation. And the goal here was, as I already mentioned, with screening mode, the goal is always to protect expert attention so that normal looking cases could be automatically reported. So in case of Cayman, our focus was on a end-to-end pipeline where we have developed a weekly supervised AI. And the more interesting work, which was led by Simon Graham in our team at that time with Dr. Fayaz and Professor Nasir, this was about interpretability. So what we did in it, that we represented entire whole slide in a form of a graph. And the good thing about graph is that it can connect different locations of the data. So in our case, whole slide image. And it also allows you to bring human annotations and human expertise in play. For example, if you see at this right side image, we have this entire graph from whole slide image, and where you can see a lot of nodes are connected, which are actually different regions. And within the regions, we not only identified regions, there is a model which tells which region this is morphologically. And also we have used a lot of cellular annotations from more than 10 pathologists working on this project with us in order to represent that particular node. And then we connected all the nodes into graph. At the end of the day, both these algorithms would tell us whether the input whole slide image is completely normal, is it non-neoplastic inflammatory, or is it neoplastic abnormal? So 2 abnormal classes and 1 normal class, that was the goal. And this is what I meant in my title slide, precision at the workflow level. And this is because our design choice is sensitivity first to include more safety so that generalization is safer. And also, we want to achieve some efficiency by reducing the burden of the work from the pathologist so that they can shift their focus from cases towards care. As you would have understood now that the high sensitivity is not a weakness here, rather it is a design objective. And screening is not diagnosis, because at the end of the day, diagnosis is a responsible clinical outcome, and this must be done not by AI, but by a human pathologist or a human expert. So what we set as a high sensitivity target was 99% sensitivity for abnormality detection. And for the likely normal cases, even the moderate specificity is enough. And that would actually mean that we can automatically report those cases, or at least we can deprioritize them. So we found that both of these algorithms, surprisingly and interestingly, got a similar result, like 55 to 56%. We could auto-report the normal biopsies, which is a huge reduction. But one more interesting thing that we found in this study was that the algorithm, the weakly supervised algorithm, was actually able to flag report slide mismatches and hard cases for for review. For example, these first two examples are non-neoplastic and neoplastic case, and these two are neoplastic cases where a tiny region is only the abnormal region here as well, and algorithm was able to pick that. And more interestingly, in the diagnostic reports, these two cases were said as completely normal, but as you can see, algorithm has flagged the polyps and adenomas, which should be neoplastic, not normal at the least. So my second case study today is microsatellite instability, a topic very close to my heart because this is the topic I started with my postdoc with. So over the years, we have seen many prediction models, starting from this seminal paper from Jacob Nicholas Kether, published in the Nature Medicine in 2019, which shows that in H&E image, we can predict biomarkers, for example, molecular biomarkers, and in this case, microsatellite instability, which is immunotherapy biomarker for colorectal cancer and many other solid cancers. We have extended that work and we pushed the accuracies from 70s to above 85, and that was published in Lancet Digital Health. And recently, more interesting work appeared, for example, MSI Intuit. This is an industry-level tool which predicts microsatellite instability, but their primary target was a little bit different than ours. It's not just prediction, but they moved from prediction to screening so that they can automatically tell, AI can automatically tell which cases are more likely to be MSS so that their care and management could be started early on. And this paper in Modern Pathology published this month earlier, and they have continued the work and introduced some pathology priors based on cellular morphologies and based on regional morphologies. They have introduced some interpretability so that they can link which morphology or cellular composition is linked to microsatellite unstable cases versus microsatellite stable cases. And my point here is that all these solutions that we have seen so far are point solutions. If we have n clinical question, which is the normal case every day, we need n such pipelines. And sometimes, like these two pipelines have many models for one task. So it is task by task AI era. So the question is, can we get the scale from this era? It appears that this is the right reason that we didn't see much launch of deep learning models deployed in the real pathology. So, and I just want to clear one thing. This story about computational pathology from day one for me is not human versus AI. It is complementary strengths of human and AI both. So clinicians here set the thresholds. AI could provide faster and safer triage, and pathologists at the end decide for each case with more safer and faster pathways. But that's not the solution. That is not telling us anything about generalization and scale at this point, because as I started my talk with, that we have number of different endpoints we want to predict. There is a shift from lab to lab, population to population, scanner to scanner, stain to stain. So we need to develop a model. And if we want to make it go through all the regulatory approvals, we need to demonstrate that it works across sites and for multiple endpoints. So that is still the bottleneck. So, and do we have a good news here? So can we shift in AI so that we can achieve both scale as well as generalization across sites and endpoints? And what we have seen so far is deep learning. And this is old, like for last 10 years, majority of deep learning pipelines were using this same old playbook. One task, now, for example, we have seen MSI screening, one task, one data set, one model, in some cases, many models for single task. And that is like not worth for pathology, because pathology is not one setting, as we described. It has to be generalizable and scalable. And the reason why these task-specific AI were breaking, because of these changes when we shift from scanner to scanner, or lab to lab, or population to population. So what's the solution? For the first time in AI history, we are now able to learn generic representation, universal representation of our data, which is in our case, millions of whole slide images from multiple population, from multiple labs, and develop a generalized representation of tissue, and then efficiently adapt it to many points like triage, subtypes, and biomarker prediction. And that's what brings foundation model in computational pathology. And this is by separating out, learning the world representation first, and then adapting to the workflow next or second. So what actually makes foundation model different is 3 ingredients, and all 3 ingredients are must. The first one is data, scale, and diversity. I'm talking about millions of whole slide images across organs and institutions. Learning objective is now self-supervised. That means we do not need any more labels for learning. AI is strong enough to learn without labels now. And last but most important bit of entire foundation model pipeline, because adaptability makes a foundation model more clinical. On its own, model is not clinical if it is not adaptable, even if it is very strong model. So model must be adaptable. Single model, single representation, adaptable to many tasks with minimal retraining. And if any one of these is missing, we have a large model, but we cannot call it a foundation model. And here I bring 2 examples, Virco2 and H-Optimus, which shows that the effort is now global and industrial, like both are these industry models. And both are these telling us another family of foundation models, which is image only or tile level encoder. And on the bottom right side, this one is industry versus academia, Prism 2 versus Titan. And this is now bringing the integration of language with the whole slide image visual features to trade off for the generalization. So as I said, that model.
Sorry, I don't know how far you are to end the presentation, but you have 2 minutes left, please, if you quickly go through the slides.
Okay, thank you. So adaptation is something that is making the system more clinical. For example, this foundation model would give us general representation in the form of embedding, which now is in the hands of clinicians and experts, so that they can teach these model clinical language by selecting the target and the problems for that. And that is called as adaptation. So this is my last case study. It's our recent benchmarking study of foundation models for the same MSI prediction task. And we wanted to see how these models generalize without rebuilding the model from scratch. We just adapted the model for this very important clinical question and very simple classification study, which can be done thousands of times in a single day for different endpoints. So these are our results showing that single model, for example, here is not only is consistently performing, which is a image language model, it is consistently performing for variant data sets and variant populations. And accuracy is not dropping. That means the shift is being handled. And this is where speciality emerges from generality. One backbone and many tasks can be adapted. For example, for the same problem, we then adapted it for visual interpretability to find out which morphological regions were high valued for different molecular subtypes. For example, plasma cells were found to be more relevant to MSI cases in like within the tumor vicinity. And also we have seen the robustness of against scales. If we shift the scale from, for example, 5, 10, 20x, so does the model still able to perform well? And we found that foundation models are better in that. So that was the goal. But we also tested that in comparison to this interpretable tool and industry tool, are we near in terms of reducing the number of tests required? So we found that at 90% and 94% specificity, we can reduce 40% or more tests from MSS from within the real clinical workload. And we have seen that these models are not just for 1 or 2 tasks. We have found that these are 11 different tasks from patch to generating a report, entire report for the case. We can do it quickly by adapting any foundation models, which tells that this is now a platform, not just another benchmark. And that brings me to the conclusion that what we can decide, like what changes for tomorrow. So to my understanding, this is not who owns the decision. The change would be really to efficiently deploy the expertise of pathologists. So precision at scale is one model which can be adapted to many tasks with less training and more reusability. And consistency is growing as the evidence is growing. So that's my last slide. So pathology is not being automated, it is being amplified, and expert attention is being scaled. And the final decision is still with the hands of human. And I would now say that it is the complementary strengths of AI and human, which is the future. And we have some work started already within Saudi Arabia with two consortium that we have recently established. And I think we would be able to discuss them in breakout rooms very soon. Thank you very much for your attention, and I would be happy to take questions.
Brilliant. Great work and well done, Dr. Mahsen. Unfortunately, we don't have time for questions, but the good thing, Dr. Mahsen will be around in the breakout room. With that, I will handle the microphone now for my colleague, Dr. Rana, to introduce the second speaker for this session. Thank you.
Thank you so much, Dr. Ibrahim. And also, I would like to thank Dr. Mohsen for his great and engaging presentation. And also, before we move on, I would like to remind all the audience to please write your question in the Q&A answer during the session. We will address them all if the time permits. Now, it's my pleasure to introduce our next speaker, Dr. Lamia Al-Subeh. Dr. Lamia Al-Subeh is a senior licensed genetics counselor and genetics specialist with extensive experience spanning clinical care, diagnostic laboratories, research program, and telegenetics. She holds master's degree in human genetics and genetics counseling, and she is among the first professionals to practice genetic counseling in Saudi Arabia. She played a pivotal role in establishing the national license framework, serving as the first genetic counseling examiners at the Saudi Commission for Health Specialties. Her contribution also include building major genomics and cancer genetics service, including next-generation sequencing facilities, national genomic database, and high-risk hereditary cancer clinics. With more than 20 peer-reviewed publications, her research spans genes discovery, variant reclassification, and clinically impactful genomic interpretation. Her current work focuses on integrating artificial intelligence into genomic analysis, clinical decision support, and population-level cancer genetics to advance precision medicine. We are delighted to have her with us today. And please join me in welcoming Dr. Al-Subeh. Dr. Al-Subeh, the floor is yours.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Is my slide showing?
Yes.
Is my slide showing? Sorry, I cannot see.
Yes, doctor. We can see your slide. You just need to project it.
Which is projected on my computer. You don't see it projected?
No. Yes. Now it's fine.
Is it projected now?
No.
Okay. Give me 1 second. Because from my end, it is already projected.
For us, it's not yet.
So just maybe wait for it.
Yes.
Is it projected now?
Yeah. Now it's fine. Yes.
Alhamdulillah.
Alhamdulillah.
Thank you so much for having me today. It's a pleasure to present This presentation introduced an end-to-end generative AI pipeline developed to enhance the detection and reporting of genomic abnormalities associated with hematological malignancies, with focus on clinical safety and expert oversight. In hematological malignancies, time is critical. In conditions such as acute bromomyelostic leukemia, sorry, even a 24 hours delay in identifying key translocations in cytogenetic can directly affect the patient's survival. Why this matters? Because cytogenetic analysis relies on noisy and highly variable karyogram images. Existing AI tools are fragmented, which means they are only focusing on either enhancement or detection or one abnormality rather than the others. With manual interpretation also is performed under tight pressure and without end-to-end validation, and with also the lack of lab staff and the high patient load in hospitals.
Dr. Lamia, if you don't mind, can you come closer to the mic, because your voice, we cannot hear it really clear.
Is it clear now, Dr. Rana?
No, can you come closer to the mic, please?
Actually, by the way, is it clear? Dr. Rana?
Actually, now we cannot hear anything.
دكتور رنا
الصوت مو واضح. الصوت بعيد ومو واضح.
الآن واضح؟
أيوة الآن واضح.
اوكي الآن كده واضح عشان بس أعرف البوزيشن.
أيوة يس.
طيب اوكي. Sorry for the inconvenience.
No, it's okay.
Okay. To assess real-world practice, we actually audited 225 cytogenetic reports issued between 2020 and 2024. The median turnaround time was 30 days, exceeding the cap recommended maximum of 14 days for reporting chromosomal analysis, indicating a clinically significant delay in routine cytogenetic reporting, especially for hematological oncology, because of the nature of the samples. We found that 30% of reports contained ISCN nomenclature errors, which means the ISCN, for those who may be questioning it, is our way of writing the genomic information and translating the karyogram images into readable and analyzable information in genetics. With minimal documentation of risk satisfaction or follow-up recommendation, and if you can see that genetic counseling was almost never suggested when indicated in any of the reports that we reviewed. So this highlights a systemic gap between cytogenetic findings and clinical interpretation. Can AI actually bridge this gap? This raises a question of whether AI can help close the gap while preserving expert judgment rather than replacing it. We designed a unified pipeline that integrated image enhancement, chromosome detection, abnormality classification, and we structuring a report, a final report for clinicians that can help them and aid them in managing their patients. Our pre-processing involves two key steps: object detection and labeling. We automatically detect each chromosome in the karyotype image and assign it the correct label from chromosome 1 through 22, plus X and Y. We also did synthetic data generation. We augment our data set by generating synthetic chromosome images paired with their ground truth, segmentation, mask, helping improve the model training, the enhancement model training. Our project cohort for training and validation, we use data partitioning across all the models track to avoid data leakage. We also, for case level testing, we evaluated the model on 183 cases. For external validation, we tested an independent cohort of 50 cases from a partner institution.
The pipeline combines BICS for enhancement, followed by 4 coordinated models for chromosome detection, numerical abnormality identification, structural abnormality classification, and automated report generation. Rather than a single model, the system operates as a collective intelligence where each component contributes complementary information to the overall end output. Phase 1 is image enhancement. So this phase, or the first phase, focuses on improving the visual clarity while explicitly preserving a diagnostic banding pattern of each chromosome. We can see that high SSIM and BCNR, which is 2 metrics for image enhancement, confirm the enhancement to improve image quality without introducing diagnostically misleading artifacts. I wrote for you below the numbers, the reference range for these numbers. So we actually achieved good ranges and good numbers in this model. This is the actual enhancement model. You can see that on the left side, the synthetic data that we generate, the ground truth, which is the actual data that we collect from the labs, and then our predicted images. So the detection by image, also detection performance decreased with poorer image quality, which is expected. The overall accuracy remains high across all the heterogeneous input, which means overall images, they achieve I would say very high accuracy for, which was really a good thing for us. Now we will go to the second model, which is really focused on detection and classification after we enhance the images that we already started with a poor quality. Chromosome detection quality for this slide or this model, the detection performance, the detection is focused on addressing the chromosome localization, numerical abnormalities detection, and 6 assignments. This karyogram triage, we used a YOLO V8 model to classify karyograms into 2 categories, either gross, which is unanalyzable, or analyzable images. Those analyzable images go for the downstream model. The gross images is a flag for the expert to review them individually. And you can see with each cross chromosome on the screen, it has the accuracy of or the detection of this gross abnormality to aid the clinician and cytogeneticist in the lab to work on these gross chromosomes. So the idea of this model is actually to flag low quality chromosomes, which is flagged with the red color on the screen. Now for the numerical abnormalities, this model detects chromosome counting abnormality and assigns 6. Basically, it's overlap 2 models of YOLO V8, one for the area and the other for the single, to give us a numerical counting for the overall karyogram. The confusion metrics on the right side show bare class accuracy for each chromosome. The key parameter that we are presenting here is 82 hard accuracy, which increased to 94 with ±1 chromosome missing or gained. And also absolute error was 0.18. And the accuracy were the 2 chromosomes that achieved lowest accuracy were chromosome 18 and chromosome 19, which is expected because of their small size among all other chromosomes. For the structural abnormality, this classifier we focused on Philadelphia chromosome because of lack of data in hematology neoplasms, but prioritizing the high sensitivity to avoid the missed high-risk cases. So basically, we have a higher sensitivity of detecting these cases, which we really look for it in clinical setting because we don't want to miss patient with these diagnoses. Now, the last model, which is model 4, is basically like ISCN aggregation of the previous information. It's collect data of chromosome counts, the numerical model, the sex assignment, the structural finding. We also are combining a clinical interpretation, a risk tier mapping from well-known guidelines published from well-known organizations. We also had a narrative translation that is CAP aligned for a report to be ready and to avoid also the errors that we mentioned in the earlier in this presentation. We also wanted to prevent the discrepancy between reports, and this way these reports can be used for further research and for future work and future satisfaction of patients based on their diagnosis, especially the genetic diagnosis, which is really important for precision medicine. Now, the end-to-end system validation, the pipeline execute successfully across all cases without interruption. All the 183 cases went through the pipeline. Now, worth note that the karyogram with gross abnormality in model 1, it's only flagged, but if the case have more other karyograms that is not gross, they can pass to the test through the model to be analyzed, and then those gross karyogram will be flagged for the clinician at the end to tell her basically what we are telling the patient, the physician, that this is your patient. It has let's say 20 images. 2 of them were gross. We couldn't analyze them, but they are here for you if you want to check them. And there is the other 18 were analyzable, and these are the result of the rest of the images for one patient. The total processing time for the whole patch was 22 minutes. The average processing time 22,000 seconds. The average processing time per case was 122 seconds, which is almost 2 minutes. 2 minutes to revise the karyogram, to flag the gross, to flag abnormality, leave them flagged for further identification and evaluation by the expert, and to generate a report. The average PCNR for the enhancement for the whole batch was 35, so we still have a good enhancement. And the average SSIM, preserving the banding for each chromosome was 0.98, sorry. And we remember that the average is 100, so.
Sorry, Dr. Lamia, to interrupt, but we have like 2 minutes remaining.
Sure. So basically, the clinical validation is image level sensitivity up to 88%. The negative predictive value was 94. Translocation case sensitivity, the Philadelphia chromosome, 94 as well. Within one chromosome, soft detection was 94% detection with one chromosome gain or low or missing. So the overall external validation accuracy was 86%. So for the application study, removing any major pipeline component from our model resulted in consistent performance degradation, so confirming the contribution of each model to the overall result. Our simulated workflow impact on the external validation cohort shows significant workflow improvement. We achieved 90% reduction in processing time from 4 to 8 hours per case, as reported by the cytogeneticist himself, down to seconds. 60% of the cases were classified as high confidence, meaning only 30% require full expert review. So we basically say that 40% of the cases is for your review, 60% of the cases is ready to go to the doctors in their clinics, which is demonstrated an AI-driven confidence metrics can support efficient triage without compromising the quality and the expert review. High confidence cases received rapid expert confirmation while complex cases are escalated for full manual review and full attention from the lab staff. we were able to integrate the system for LIS integration. So this is a report in a PDF format, ready for uploading in any healthcare system in whatever hospital. We have the risk tier for the clinician. We have the interpretation method, no missing information, the ISCN updated up to the last version. And this is the ground truth, the many images of one patient with the leukemia trisomy 8 scenario, and this is the model output. A report with also a detailed image flagging for further assessment. So this is basically the online platform for us, where you can put your patient information. This is the one that used for external validation. You can put your data, and then this is what you get. Flagged image, PDF report, and ISCN information. So basically, our contribution, this work deliver a clinic-ready prototype with future effort focused on broader structural abnormality other than Philadelphia chromosomes, and to also expand the catalog, clinical ready and fast. LIS integration, we wanted to be a secure app for all physicians in all over the kingdom, for remotely access for those who have no access to tertiary hospital or reference labs. In summary, we demonstrated a safe end-to-end pipeline that accelerates cytogenetic workflow while preserving clinical integrity. We're really happy with what we achieved in this model. We heard the feedback from the cytogeneticists that we worked with them, and we hope that one day we can deploy this prototype for people and patients in Saudi Arabia for their benefit. So thank you for your attention. We think that this is doable. This is the idea of presenting this work, that this is doable from weeks, almost 30 days into 2 minutes. We hope that one day we can achieve this in the near future, inshallah. Thank you so much for listening.
Inshallah. Thank you so much, Dr. Lamia, for this impressive presentation and valuable data. Because of the time consumed, so we will like to conclude here our third session, and I would like to and please note that Dr. Lamia will not be available in the breakout room. And I would like to thank all the speakers for their valuable and engaging contribution. Thank you so much. And we'll move now for the fourth session, inshallah.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. My name is Sara Al-Fadda, a professor in prosthodontics at King Saud University. Together, my colleague, Dr. Wajdi bin Muhammad, and I are delighted to be chairing this session. And I would like to welcome you again to the symposium. And to begin with, without any further ado, I would like to introduce our first speaker, Dr. Abdulaziz Al-Ashawi. Dr. Abdulaziz Al-Ashawi studied dentistry at King Saud University in Riyadh, Saudi Arabia. Then he completed internship training at the ER and Special Need Clinic at King Saud University and Prince Sultan Military Medical City. He participated in several national and international conferences and meetings in the field of oral medicine. Also, Dr. Al-Ashawi is currently appointed as a general dentist at Dr. Abdulaziz Al-Ajaji Dental Clinics and Dr. Sulaiman Al-Habib Hospital. A little housekeeping before we begin. I would like to remind the audience to please post any questions that they may have in the question and answer box. And now I will turn the session over to Dr. Al-Ashawi for his talk. تفضل Dr. Abdulaziz.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullahi wa barakatuh.
My slides showing?
Yes, it's clear.
Good morning, everyone. My name is Al-Ashawi, and it's my pleasure to present my research today. And I would like to thank Prof. Asma for inviting me for this event, and also the whole organization for the wonderful gathering. Today, we will be presenting our research title, which is Enhancing Jaw Lesion Diagnosis, Digital Histomorphometric Differentiation of OKC and Ameloblastoma. To give you some background, odontogenic cysts and tumor presenting a diverse group of lesions with variable clinic behavior and management. Among them, odontogenic keratocysts and ameloblastoma exhibit the most aggressive behavior. The accuracy of diagnosis is essential for appropriate treatment planning and also patient care. However, the key epithelial features are often masked by inflammation, so it will make more diagnosis challenging. Therefore, an objective quantitative of the histological feature may help improve diagnostic confidence. Classically, OKC is characterized by the parakeratinized epithelial surface and palisading basal cell layer, while the ameloblastoma shows peripheral palisading with reversed nuclear polarity and the satellite reticulum-like cells. The main challenge lies in the subjective interpretation, especially in the presence of the inflammation, which distribute the classic architecture. Inter-observer variability among the pathologists. Of course, this challenge is not limited to the OKC and ameloblastoma, but it extends to other odontogenic lesions such as dangerous cyst. This is our hypothesis, which is artificial intelligence-based analysis can assist in differentiation between odontogenic cyst from ameloblastoma. And our aim is to evaluate whether AI-driven quantitative epithelial analysis of continual H&E slides can distinguish OKC from ameloblastoma. Here's the overview of our methodology. Begin with the IRB approval was obtained and the cases were collected from the archive files. And the inclusion criteria was the confirmed histopathological diagnosis and well-preserved epithelial lining components. And for the exclusion criteria, which is cases with inadequate medical record and extensive tissue artifact or even insufficient epithelial component. And also for the slides were scanned to generate the whole slide images were analyzed using the QBath. Also for extracted, the feature were exported and statistical analysis. To report further, the whole slide image were reported in QBath is an open source software for digital pathology and machine learning analysis. The epithelial region were manually annotated and verifying by expert pathologists. For the morphological and spatial features were extracted, the data were exported to Excel and subjected to statistical analysis. This slide shows an example of annotated epithelial regions of interest, the cell detection using the QBath and the OKC, as we see here. This graph, here also another example of demonstration, epithelial annotation and cell detection in the ameloblastoma case. This graph shows the result of morphological feature analysis included the nuclear and cytoplasmatic shape and size, and hematoxylin and Eocene staining intensity. And we observe the significant difference between OKC and ameloblastoma in nuclear cell clarity, and also for Eocene optical density, both in nuclear and the cytoplasm. To interpret these findings, nuclear cell clarity was increased in the OKC. The OKC nuclei tend to be more rounded, while ameloblastoma nuclei are more elongated. And for the biological meaning, OKC epithelial is uniform and cyst-like lining. In contrast with ameloblastoma, shows new plastic epithelial profilation with a shape variability. This aligns with classic histology and biological relevance. Eocene optic density was higher in OKC, indicates that greater Eocene uptake, supporting the difference in epithelial differentiation. And there's no strong difference in hemotoxinin between ameloblastoma and OKC. This shows that the difference are architectural and organizational. For the nucleus to cell ratio, it's almost similar. So this reinforcement that sample cytology alone is inefficient to separate them. We also performed a spatial analysis, which is examine how the cells are arranged related to others. The significant difference was was found between an OKC and ameloblastoma in these three parameters, which is number of neighbors cells and the intracellular distance, and lastly the mean of triangular area. All these spatial parameters were increased, including the number of the neighbors increase in the OKC. This reflects tightly packed epithelial lining in the OKC. The main intracellular distance increase in the OKC. This showed that regular spacing across the flat epithelial and less architectural complexity. For the main triangle area, it's also increased markedly in the OKC. That indicates more regular units in the OKC and reflect smaller triangular area and epithelial expansion into stroma in the ameloblastoma. Here we performed a SHAP analysis as illustrated in this graph. This analysis is used to identify which feature contribute more to differentiation between the OKC and the ameloblastoma. As shown here in the top left of the figure, nuclear cell clarity and the mean distance are ranked among the most influential feature contributing to the model decision. Like in a study, our work has been some limitations. First, this is a single central study, which may limit the generalizability. Also, for the retrospective design may introduce informational bias. In addition, the sample size considered relatively moderate, and we are planning to increase in the next step, inshallah. For there are several future direction are planned. These include multiple central validation to assess the robustness and generalizability of the model, of course. We also aim to further refine the model through the collaboration to improve reliability and also for the prospective clinical evaluation to assess the real-world performance and also for the clinical applicability. To conclude, the qualitative epithelial histopathology can transform routine H&E slides into objective diagnostic signals. We would like to thank our supervision for their guidance and support, including Dr. Ibrahim Al-Sani, also the histological laboratory in the University of Dental Hospital, the HistoApp company, and the College of Dentistry, King Saud University. Thank you for your attention, and we'll be happy to answer any question, even in the another meeting, or this is my email to elaborate any further question. Thank you.
Thank you, Dr. Abdulaziz. Again, I would like to remind everyone, if there are any questions, to type them in the question and answer box. We have a few minutes to spare before we move on to our next speaker. Dr. Abdulaziz, if I might ask you a question, what would be the take-home message to a clinician like us who see patients in everyday clinic and wonder what could be something that they would apply if they are to contribute to these science, if this information gonna help them in their clinical practice tomorrow, for example?
I would like to say that using the AI for the diagnostic for some slides or even a clinical picture in the clinic, they can use many or multiple application. For example, as we use in this research, QBath, it will be help them to differentiation between many cases, especially in the ameloblastoma and OKC. There are also multiple legion we can differentiation between them, but recently there is no clinical based or clinical trials that make evidence about if, the legion itself, if it will be really significant or not. But we would like to say that we can use the AI to just help us and differentiation between the legions. So we don't like just rely on this application until now, and inshallah in the future we can just put the picture of the slide or even clinical photo, and we can just reduce the diagnosis or even also the treatment for these lesions.
I believe Dr. Rana has a question for you in the question and answer box. Any previous studies to compare ameloblastoma and OKC using AI?
Nowadays, there is not yet a specifically research comparing from ameloblastoma and OKC. There are a general perspective about comparing from different legion or even a bacteria, or let's say about the caries, for example, in the same teeth. But particularly for the ameloblastoma and OKC, there is no research that comparing between ameloblastoma and OKC.
Okay, thank you very much, Dr. Abdulaziz, for such an insightful presentation. And I would like to hand the mic to my colleague, Dr. Wajdi, to introduce our second speaker. Thank you, Doctor.
Thank you, Dr. Abdulaziz, once again for this informative topic. Moving on and in continuation along session 4's topics, it's my pleasure to welcome and introduce our next speaker for this session, Dr. Abdullah Abu Jami', who will be presenting on MRI pulse sequences for dental imaging. Dr. Abu Jami' is an associate professor and consultant in the Department of Radiology and Medical Imaging in the College of Medicine, King Saud University, and currently serves as a head of the Medical Physics section. He earned his PhD in the Medical Physics of Magnetic Resonance Imaging from the University of Nottingham in UK, in the United Kingdom in 1999. Mashallah, with his extensive expertise in MRI physics and imaging applications, Dr. Abu Jami' brings a unique and valuable perspective to the evolving role of MRI, خاصة especially in the dental world. We are honored to have him with us today and look forward to an insightful and enriching presentation. Doctor, the floor and mic is yours.
السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله. صوت واضح. Presentation we have it here clear.
Perfect. Thank you so much for having me. I would like to thank the organizing committee, especially Prof. Asma'a, for inviting me and for organizing this amazing activity. My topic will be a little special and relatively new to MRI technology. The main learning objects of our talk is understand challenges of MRI in dental maxillofacial imaging, review MRI pulse sequences relevant to dental application, compare sequences for hard and soft tissues visualization. Again, we see future directions. First, I want to disclose that I don't have any conflict of interest related to this presentation. The question is why MRI for dental imaging? As we all know, MRI doesn't have any ionizing radiation, so this is one of the add values of MRI. It is excellent soft tissue contrast, useful for TMJ bulbs and periodontal tissues, nerves. Emerging techniques in MRI make an open door for hard tissue imaging as well. Main limitations is the susceptibility artifacts like air, metal, and also limited signal from enamel and dentin. So if we just go through the publications in the field of dental imaging, we will see it's like growing from 2000 up to 2004, like for example, like 5 or 10 times. The main applications for MRI in dentistry, it's like this is one of the oldest applications, which is using an MRI to see the TMJ disorders, assessment for salivary glands pathologies, oral cancer and tumor imaging, dental implantology, and again orthodontics and endodontics. Also pediatric density, since we don't want to expose them to too much radiation. Sometimes MRI will be like a choice. So what are the challenges? The main challenge of MRI is that it has a very short, if we speak about hard tissues like enamel and dentin, they have a very short T2 or what we call T2 star. And this makes it very difficult to capture the signal before it decays. In general, MRI is used extensively in soft tissues because they have acceptable time of decay, which we will be able to detect it before it vanishes. But if we talk about like hard tissues in dentistry, like 40 and 50% of the minerals by volume, and this makes like a very difficult to have a signal. And the other reason is that those hard tissues have a very little hydrogen that can be detected. So these two sources of challenge make the MRI one of the limited use in the technology of diagnostic imaging in dentistry. So the other challenge is that air tissue interface. Again, this is one of the chronic artifacts in MRI, which cause susceptibility artifact in the base of a skull or in the areas of where we have an air soft tissue interface. As you can see there, nothing can be seen at this sequence. Again, metallic restoration and orthodontics, those one of the challenges usually that can cause a severe distortion of signal at the site of the implanted hardware. For example, there we can see nothing can be seen at this slide. Again, the requirement of a small field of view is another challenge where we have an MRI and technology. The more you reduce the field of view, the more loss of signal, because we struggle to get more protons. Once you make your field of view smaller, it means that you're losing a lot of hydrogen signal, and as a result of that, we will have noisy images. But with the new technology, the images can be acquired with a reasonable quality. So that means we need a high field MRI and dedicated RF coils to enhance the MR signal. And as we can see, this is an images from 3 Tesla and 5 Tesla, where we can get a reasonable MR signal. Again, dedicated coils can be utilized, as you can see with this 16 channel or 15 channel coil can produce an excellent image quality for the jaw and dental. So the basic sequences you utilized in an MRI, quickly we have like RF excitation and relaxation. So historically, we use the spin echo, where we apply an RF pulse and then the protons start to dephase, and that makes the signal decaying at having this kind of shape. As I said, hard tissues usually they decay fast, which make it difficult to detect a reasonable signal from that signal. We have two things that we have to see the response, where we will call the decay, the transverse decay or T2 signal. That's maybe most of you are aware of T2 images. And then also we have a T1 recovery, which the protons recover to the, and that can produce the T1 images. So as we compare the soft tissues, for example, they have a long echo T2 time, which we allow us to pick the signal or to detect the signal. While if we see, for example, dentin or dental enabled, they are very, very short. So it's like in 0.15 milliseconds or 70 microseconds, means that they will decay sharply before we are able to detect any signal from that tissue. The main two major sequences used since the history from MRI are spin echo and gradient echo. And spin echo apply 90 RF pulse, and then we detect the echo of the signal, and that's why they call it a spin echo. While in the gradient echo, we have only one radio frequency pulse, and then we use the gradient or the magnetic field itself to refocus the proton. As you can see, that's inverted 180, but in a gradient, it's like inverted in the transverse horizontally clockwise and anti-clockwise to form the echo. The role of the parameters like TR and TE can enhance or highlight a specific contrast in the images. So we can have, for example, fluid bright, or we can have the fluid dark or gray. That's what we have. We call it in MRI T2 images, T1 weighted images, or proton density images, and so on. Spin echo, it's like, as I said, it consists of like 90 and then 180 RF pulse, and from that we will generate a signal until like it's like an old technique and a slow technique. So it was used and utilized for longer time. It is stable and it can be very useful for soft tissues, and also limited for hard tissues because it requires time to capture the signal. On the other hand, turbo or fast spin echo, it runs like multiple echoes, which make the scan time faster. So nowadays, this is the horsework of most of the MRI images is the fast spin echo because it can acquire more lines per excitation. So it reduces scan time to like 5 to 10 minutes. I mean, the total scan time can be up to 15 minutes using this kind of imaging. Again, it is good for reducing an artifact, as we can see, comparing a spin echo with a fast spin echo. The idea of having multiple 180s can help to reduce the susceptibility of it. So we can see A spin echo has a very limited artifact compared to other kind of sequences like gradient echo and echoplanar. It is used again in TMJ applications, predominant against soft tissues, inflammation, and edema. It can be utilized in both T1, T2, and proton density. As I said, it's most of the scan based on these kind of sequences, especially in dental application. The third type is the gradient echo sequences, which is doesn't have 180 RF pulse. It is replaced by a gradient reversals that can help to produce the signal. It is very sensitive to susceptibility to metallic implants, or as you can see, compared with the gradient with the spin echo, it's completely distorting the signal. But the advantage, it has a very short TE where we can capture the signal before it decays. And this is the challenge in dental hard tissues, is that we need to capture the signal in a very short time. So gradient echo can capture like a milliseconds tissues, in T2 tissues. Also, it is faster than spin echo. It is, as I said, very susceptible or sensitive to metal and air artifact. And recently emerged techniques like ultra-short echo time is especially important for dental application, since it can capture a very short T2 tissues. Tissues less than 100 microseconds can be picked with the sequence. So the idea behind this sequence is that can be applied in very short RF pulse, and again use a very short gradient refocusing with kind of projections, multiple projections to capture the signal before it dies. Again, it captures the signal from short tissues. For example, tissues like enamel and dentin can be visualized with, this is, for example, short TE or zero TE scan. Again, as you can see, the images can show us some of the signal. Again, another modification of ultra short, which we call it zero TE, where we start to acquire the signal before it decays. As you can see, we start the acquisition before the starting of the excitation. So receiving starts earlier, so virtually there's no echo time. That's why they call it zero echo time. The same idea, we are using projections with one gradient continuously open, with those three gradients can be switched according to the direction until we fully reconstruct the images. The advantages, it's excellent for hard tissue. So as you can see, this is an example of CT compared to MRI zero T images. Again, we can compare like T1 gradient echo with a spin echo, and this is for zero TE. So this kind of imaging opened the door for imaging hard tissues, as we can see there. And that is an irrelevantly new technology. It has a limitation that it has a very low signal to noise ratio tissue. And this means that, again, it is lower soft tissue contrast. As I said, it's the signal is very low from there, so we have to excite more and more time. The scan time is longer. For now, it requires at least 7 minutes for each sequence. One more modification is called Swift, which can use continuous RF excitation. As you can see, with continuous excitation, not only a single RF pulse, but multiple with continuous excitation. Again, it has excellent images for hard tissues, but again, it suffers from scan time is a little bit long still for this kind of applications. In general, contrast MRI can be divided into two T1 images where we measure the recovery of the tissues. So we have tissue A and B. We need to capture how fast each tissue is recovering, and accordingly, we capture the images at different points. As you can see, we will have like a T1 contrast can be enhanced. It is excellent for anatomy and also and bone marrow. On the other hand, T2 weighted images and dental applications, they use, for example, in soft tissues. In this case, we have to extend our acquisition time to see the dephasing of the signal in the transverse plane. This is excellent for inflammations and TMJ disc pathology, since it can like a cyst or inflammations where edema is accumulated. Proton density images is really the choice for orthopedic imaging and also for dental imaging, because it can, in proton density, we use long TR and short TE. It has a higher signal to noise ratio. It is a choice for TMJ applications and periodontal assessment. The fusion weighted images, again, in MRI, it's one of the recent applications, relatively new in MRI. It is sensitive to molecular water motion. It's again based on a very fast technique that can be switched quickly to measure the molecular level movement of the proton, and it can show, for example, in the free movement, we can see that protons are free movement. So when we apply two gradients, we will not see anything. On the other hand, if we see restricted, for example, patient with infarction or tumor, where we have a higher cellularity there, the protons will be restricted and the MR signal will be detected like a high signal intensity. So this is an example of diffusion in neuroimaging, like a stroke. But in dental applications, it's excellent for tumor characterization. And as you can see, this is an example of using a diffusion weighted images in cell carcinoma tumor in a mandible in the 61 years old male. Again, this is another example of hemangioma, as we can see it there. Again, it can be utilized in infections to differentiate between infections and inflammations. Again, as I said, one of the main challenges in dental imaging is that susceptibility to artifact. Again, to reduce the artifact, we normally tend to use spin echo rather than other gradient or echo planar. So this is an example of comparing a spin echo sequence to a gradient echo. And the patient, if you have a small fragment of metal, that can cause a severe distortion of the images. Again, this is a gradient echo, and compared to spin echo, we can see there's a little distortion in the images. Using short TE techniques, as we just described, ultra short TE or zero TE, using a high bandwidth. As you can see, this is two images, one with a high bandwidth, and this is with a low bandwidth. The improvement can be seen clearly. Using a dedicated dental coils, again, using a dedicated metal artifact reduction methods, as we can see, some sequences, again, used in MRI, like Maverick, Mars, they can reduce the metal artifact, so the surrounding tissue can be seen. This is just a quick comparison.
Yes, we have 2 minutes left.
خلاص إن شاء الله last 2 slides. So this is a quick comparison between the sequences. Future directions with dedicated dental MRI scanners now is almost available. So you can see this is scanner provided with the 16-channel dental radio frequency RF coil, where the images can be, again, AI assist reconstruction and diagnosis, which again can reduce the time for diagnosing. Conclusion: conventional sequences are optimal for soft tissues. Ultra short TE and zero TE enable hard tissue imaging. Dental MRI is evolving with promising clinical potential. Thank you.
Thanks a lot for a very insightful topic, Dr. Abdullah. I believe we have perhaps 1 minute. If there are any quick questions, or we can, of course, go take those questions to the breakout rooms later at the end of the session after 20 minutes, inshallah.